Well, good afternoon, and thank you so much for joining us for day 4 of our third annual Inclusive Excellence Week here at the VCU School of Dentistry. It is really my privilege. We have such a powerhouse with us today. It's a great treat to have Lisa Simon here with us, who's going to be talking about advancing equity through medical and dental integration. Lisa will probably tell you a little bit more about herself, but she is a physician and dentist at the Harvard School of Dental Medicine and Harvard Medical School. Her research and advocacy center on the health policy implications of the separation of medicine and dentistry. She is proud to practice both primary care medicine and dentistry in safety net settings. And she's a brand new mom with a 10-week-old or maybe 11-week-old now. And I've had the honor to be on a couple of panels and do Zoom webinars with her in the past. So I'm just really excited that she had the ability to join us and is off maternity leave, joining us in person here today, or virtually, I guess you'd say. So we'll give it to Lisa. We'll take questions at the end. You can put those in the chat feature or the Q&A feature. And once she's done with the presentation, we'll have a little bit of Q&A and dialogue there. So take it away, Lisa.
Thank you so much. And thank you so much for having me. I'm truly honored to be a part of such an important week of programming. I hope this is really helpful and fun for everybody. And also, I just want to see that some of the names in the attendee list are people whose work I really admire. So it's truly an honor to get to talk with all of you. I hope it becomes more of a dialogue as we go. So I'll just share my screen and we can get started. All right, advancing equity through medical and dental integration. And I'm a bit of a history nerd myself. So I like to start with just a question, which is why are medicine and dentistry separate? And I often find, especially when dental students think about this question, they tend to think of it from a very concrete or present focused reason. But the reality is that it's actually just sort of a historical fluke that really comes down to these two guys. I don't know if anyone recognizes these daguerreotypes, but the person on the left is Dr. Chapin Harris, who founded the University of Maryland Dental School. And the guy on the right is Nathaniel Cooley Keep, who founded Harvard in the left in the 1840s, on the right in the 1860s. And I think it's important to emphasize both of these men were physicians who identified that having people with skill in dental care would provide better care for individuals, and therefore started schools of dentistry. But of course, when schools of dentistry start, they become different or separate from schools of medicine, and we have an entire sort of branch point all from one pretty well-intentioned decision. And I'll just point out that for these men who were themselves physicians, that separation was non-existent. So I don't know if anyone else is a New Englander, but this is a pretty famous sort of piece of Boston medical history. This is the Massachusetts General Hospital ether dome, which was the surgical area in the hospital because it was the highest up, so it got the best light. And this is the first use of ether anesthesia in North America. And they're doing some sort of horrible surgery. Thank goodness that man is anesthetized. But I'll just point out that the person who is giving the ether anesthesia, William Morton, was a dentist and actually brought it into medical care. So again, in this sort of 1840s era, these differences were sort of theoretical or non-existent at all. Moving a little bit forward in time, this is Dr. Painless Parker, who in 1932 actually had a 5-year suspension of his dental license for 2 reasons. One was advertising, which the ADA believed was unprofessional. I think the ADA has kind of changed its tune on that one. And the second was for involving non-dentists in the delivery of dental care, which obviously in the world of oral health integration is still pretty salient and important to us today, and maybe is something that the ADA is still struggling with. The fun fact for Painless Parker is that because he almost lost his license for claiming he was painless, he actually legally changed his first name to Painless so he could advertise himself as Painless Parker. And this is a little bit of a less fun history lesson, but I do just want to give a little bit of an overview of the ways insurance has evolved over time, because that really has compounded the separation that we see in education and practice, like I described. So in the 1900s, medical insurance originates from this idea that a catastrophic medical event shouldn't lead to catastrophic expenses, sort of pooled risk, like a group of school teachers all putting in money so that if one of them is hit by a horse and buggy, they can still go back to being a teacher. In contrast, dental insurance really evolved about 50 years later as a perk through union membership. So to support labor forces, but really offered in almost the opposite way. So instead of paying for large catastrophic expenses, dental insurance will cover anticipated small expenses, say a cleaning or an annual exam, but covers proportionally less and less of much more expensive procedures. For those of you who are in practice as dentists now, you may recognize that that's basically exactly how dental insurance still works today. Over the course of that time, there have been repeated proposals to develop nationalized healthcare schemes that included dental benefits as well as medical benefits. And in 1965, both the American Medical Association and the American Dental Association united to oppose Medicare and Medicaid. The difference is that the ADA won in that dental care was initially excluded from both Medicare and Medicaid, and the American Medical Association lost their goal of not being a part of this. In 2010, the Affordable Care Act led to landmark changes in access to care and insurance coverage for many Americans, but generally excluded dental care, with the exception of perhaps some slight increase in dental coverage for people who were part of groups that expanded Medicaid from 100% to 138% at the federal poverty level, some children who were able to stay on their parents' insurance until age 26, and some people who chose to purchase pediatric dental coverage on the exchange. But overall, not a huge change, especially relative to what it did for healthcare. And I'll just note that the way things work here in the United States is, again, mostly a fluke. It doesn't have to be this way. In many Eastern European countries, dentists attend medical school and then specialize in stomatology, the way you might specialize in dermatology or ophthalmology. In many Western European countries, dental insurance is integrated into national health insurance schemes, like in the NHS in the UK. And of course, in 54 other countries, as well as a few states and many sovereign tribal nations within the United States, dental teams include dental therapists or other team members, which is different than how it is practiced in most other states. So I want to talk a little bit about oral systemic health, a term that you will learn I don't love, because I think that this is often a center point of conversations around oral health integration. And I want to talk to you about why I think that's a mistake. So these are some quotes that might seem familiar to you. Oral health is a critical part of overall health. Annual healthcare savings of more than $1,000 per capita have been realized when periodontal treatment is provided to high-risk groups. Studies have previously demonstrated the relationship between periodontal disease and inflammatory markers associated with diabetes severity. And I will tell you honestly that these are all sentences that I have written in papers I've published. But I want to dive deeper into the best data we have to support these claims, and then hopefully, along with you, create a paradigm shift for how we talk about this. So this is a randomized controlled trial of people in the Veterans Administration with diabetes who receive periodontal scaling and root planing for their periodontal disease. And this is looking at their hemoglobin A1C, or their level of diabetes control before and after receiving that treatment. As many of you probably know, a randomized controlled trial is sort of the best quality evidence we can hope to get. And in fact, the study was stopped prematurely because of a lack of efficacy. This is an observational study, so no longer sort of best quality, but looking at people with chronic kidney disease and their survival rates over time, which confusingly found that people with periodontal disease lived longer than people without periodontal disease. This is a systematic review looking at all of the body of published literature on the outcomes of people with periodontitis and cardiovascular disease, which did not actually find any reliable evidence regarding prevention of CVD through treatment of dental problems. And this is an article now fairly old from 2006 that was a randomized controlled trial looking at providing scaling and root planing for women who are pregnant who had periodontal disease, which ultimately did not find any significant changes in rates of preterm birth, low birth weight, or fetal growth restriction. This is another systematic review that we actually published in JADA a few years ago, which looked at the claims of cost savings for providing SRP for people with periodontitis. And as you can see, there's actually a pretty broad variation in what's reported in the literature. I'll let that sink in for a moment. Sometimes people feel a little concerned about seeing some of this data, and I hope we can talk about it further. But I do just want to emphasize that this data is not the only thing. And I want to point out that relying too heavily on this sort of association is undervaluing what we do. When we say oral health is associated with many systemic health conditions, what we risk people hearing is oral health is only important because it's connected to health conditions that actually matter. When we say dental care may lead to overall healthcare cost savings, what people could interpret is if dental care isn't cost effective, it's not worth providing it. And when we say dental disease has a bidirectional link with inflammatory chronic diseases, what people could interpret that as saying is dental treatment should only be covered for people with certain conditions. And we'll talk later about some of the implications in current health policy. Even when we talk about the oral systemic health link, we're talking in a way that the rest of our body doesn't function. We don't talk about liver systemic health or cardiac systemic health. We're keeping ourselves separate. So I would argue that even the way we contextualize the work we hope to do needs to change. So if our value isn't in improving hemoglobin A1C or preventing heart attacks, or at least the data to support that that is our value is still quite nascent, how do we talk about the importance of oral health and what it means for integration? And I would argue that this is it. Some of you may be familiar with a scene like this. This is a picture of a remote area medical dental mission in the United States. Every time I look at an image like this, I'm struck by how deeply dehumanizing the care is, how close together everyone is, how little personal connection most of these patients are able to make with these dentists who they'll never see again. And also the desperation that people must experience in order to wake up at 3 a.m., enter a lottery system, wait in a gymnasium or a racetrack or wherever to get the care they need. And the fact that this is happening within our own country is horrifying to me, and I hope to you. I'm sure almost everyone on this call knows Diamante Driver. And what's not only tragic about his death at age 12 from a brain abscess caused by an untreated dental infection, but the fact that his heroic mother called almost every dentist who claimed to accept Medicaid in the state of Maryland, trying to save his life and ease his suffering. We have, as again, many of you likely know, very good evidence that there are absolutely unacceptable inequities within oral health outcomes that divide along racial identity, as well as other factors of identity, such as gender and sexual minorities, rural dwelling, people who speak a language other than English primarily. And I'll just allow you to read some of these statistics, which unfortunately are probably well known to you. And when it comes to income, of course, there are just as dramatic disparities and inequities. Essentially, in the United States, we can assume that if you are relatively well off, you will likely never have a toothache and have access to dental care from childhood. And if you are low income in the United States, your experience of oral health care will be almost entirely different, and you will most likely have dentures at some point in your life. This is a study where I looked at access to dental care in privately insured people before and after a hospital stay, and found that even among people who had dental insurance and a visit prior to their hospital admission, there was still a dramatic decrease in rates of dental utilization in the year afterwards. So this shows that instead of being an opportunity to connect people with care, which a hospital stay often is for other aspects of healthcare utilization, when people enter the medical system, it actually decreases their opportunity to access dental care because of our separation. On the flip side, there's optimism, which is that when we actually integrate this, for example, in a study of a large health system that implanted nurses within dental clinics to help provide routine primary care, people were actually able to better get care. And I'll also point out that when we talk about integration, we're integrating something that patients are already seeking in the medical system. 1.5% of all emergency department visits are for dental problems, but only about half of those individuals actually are able to see a dentist 6 months after they first present to the ED. And almost the same number of hospital admissions are for a dental problem. And in both of these cases, there are people who pass away as a result of their untreated dental disease. I'd also just like to emphasize that looking at something binary like death or cost is not the best way to understand the lived experiences of these people. But we don't have good data on what it means to have this sort of experience with the health system and with dental care. And so I can't show you a metric of their suffering or their experiences, but hopefully this data will do the trick. And as we can see, and as we've discussed previously in this talk, essentially access to dental care is a better marker of income and general socioeconomic status within the United States than it is even a predictor of those things. In some ways, I find research on oral health outcomes to be particularly challenging because in a way, access to dental care is itself a confounder because for many low-income people, it's simply too challenging. So with a goal to switch a little bit to optimism, let's talk about what oral health integration should be. I'm going to start by problematizing what it can look like, and then hopefully that will lead to some conversation and ultimately some blue sky thinking where we look beyond what's happening now. Should we be asking primary care doctors to screen for oral cancer? On the one hand, the United States Preventive Services Task Force actually provides insufficient great evidence to recommend this. So they're not recommending that primary care clinicians actually screen for oral cancer. At the same time, though, 90% of Medicare beneficiaries with metastatic oral cancer, so stage 4, saw a physician in the year before they were diagnosed, and 50% saw more than 11. So what's the right thing to do here? What should integration look like? Again, the United States Preventive Services Task Force recommended screening for high blood pressure in all adults. On the one hand, this seems to invite that the dental setting should be the perfect place for people to be screened for high blood pressure. But on the other, there's pretty good evidence on the flip side that screening for blood pressure without having sufficient management may actually just lead to people not being able to get dental care if their blood pressure is elevated above a certain level without actually ensuring that they have their blood pressure managed appropriately. In the earlier days of the COVID-19 pandemic, there was a lot of excitement for dentists to be able to deliver COVID and other vaccinations. Certainly, that's another setting where people might already be, who could be then who could have discussions and be motivated to receive vaccines. But when you look at the operationalization of this, the rates were extraordinarily low, with only about 2% of dentists delivering COVID vaccination, and very, very low numbers of people providing things like HPV vaccines or flu vaccinations. So that's where we are now. Where should we be going? And I want to talk about a few particular topics that are near and dear to my heart, in part because I think that they are really important potential drivers of equity, and where communities have already been very vocal in their needs and the importance of these topics. So very briefly, let's discuss dental therapy. Hopefully everyone is at least passingly familiar with what a dental therapist or DHAT is, but they are a clinician who works alongside dentists in a role similar to a nurse practitioner or physician assistant in medicine. They can do some, but not all of the procedures that a dentist can, and they essentially expand the dental workforce and provide care on a team with a dentist, dental hygienist, dental assistant, and so on. When we look at outcomes on teams that include dental therapists, we find that there are actually reduced levels of caries and essentially better outcomes. So the data to support their adoption is quite good, even if the actual implementation of dental therapists in the United States, at least, has lagged. What's interesting from an oral healthcare integration perspective is that there have been similar controversies within medicine dating from the origin and introduction of NPs and PAs about 50 years ago, with similar findings. So this study was published relatively recently, but has been extraordinarily consistent within the literature, which is that teams that work with NPs and PAs, or NPs and PAs themselves, are actually just as likely to provide high quality care as teams without them, but tend to also sort of improve care and broaden the primary care workforce. Seems like something that should be a no-brainer to apply to dentistry, and yet. The other thing I'll point out about dental therapy is that it is an amazing example of listening to our communities and empowering community voices. So Indigenous nations within the United States have been some of the most vocal developers and advocates for this form of dental care delivery and team building. I'm just portraying some of the incredible organizations who do this work here. Within the Indian Health Service, there is still not a widespread adoption of dental therapy, but specific sovereign tribes have included it, including the Swinomish in Washington State and in the state of Alaska. Elsewhere, things have been a bit more challenging. This is a really hard slide to read, but that is the point. This is looking at various training and licensure requirements for dental therapists within the 12 states that have currently passed laws allowing them to practice. And you can see that the numbers of hours of direct supervision, what kind of degree dental therapists need to have, where they can practice varies enormously. And that these hours of direct supervision are extremely high, up to 2,000 hours. In essence, these rules are legislating dental therapists away from being able to do the work we know that they can do. Moving on to dental insurance. Many of you may have followed that in the summer and fall of 2021, there was a lot of excitement about the potential for Medicare to be expanded to include a dental benefit. This was included in both President Biden's Build Back Better bill, as well as within legislation that was proposed in both Congress, in both Senate and House of Representatives, was passed in the House of Representatives, but ultimately didn't get much farther than that. So this is the hot new thing. In July of this year, Medicare actually made a proposal that rather than expanding it through legislative action, there could be comment for the potential increase in Medicare dental coverage for medically necessary dental procedures, which is an interesting framing given what we've talked about before in terms of what medically necessary actually means. So the first thing is to highlight that many dentists were quite in favor of this, dating back to when the initial proposal in the 2021 was floated. So this is an incredible letter from the National Dental Association. Many other dental associations also supported it, with the important exception of the American Dental Association, which was vociferously against the potential passage of this bill. More recently, this is from the Santa Fe Group, a think tank focusing on oral health outcomes. This is an exceptionally long letter with about 100 citations, all of them reporting the ways that oral health is connected to overall health and what Medicare should perhaps cover. And I will note that this is a really important letter within the context of what the Center for Medicare and Medicaid Services is asking for. But again, just to problematize what we mean when we think about medically necessary dental services is something I think it's important to do. This is a graph from my own research that's currently under review, which looks at the change in complete edentialism at age 65, which is the Medicare eligibility cutoff. You can see here that there's actually about a 6% jump in complete edentialism right when people turn 65. Most likely because individuals with a failing dentition who are losing their insurance are choosing to have their teeth removed before they reach Medicare eligibility. So you can see that there is the potential for a Medicare dental benefit to really dramatically decrease complete edentialism among older adults and all of the negative consequences it leads to. But when we talk about medically necessary dental care, it's very rare for us to think about it in a global manner that's actually person-centered. Here's another potential impact, which is showing that individuals with Medicare who go to a dentist spend about $1,000 a year out of pocket on their dental care. This is another serious consequence that a medically necessary dental benefit wouldn't necessarily have the capacity to manage. Even though this might affect individuals with certain chronic conditions who could have some dental coverage, it leaves a lot of people without those conditions out in the cold, even if they're spending $1,000 they may or may not have on dental care every year. And just for some external context, this is from the 2008 Medicare Improvements for Patients and Providers Act. And what this act did, among other things, was ban a differential in co-payment costs between behavioral health care and overall medical care. And I appreciate this most of all as a model for dental care, because how it was described is an elimination of discriminatory co-payment rates for Medicare outpatient psychiatric services. Note that this doesn't say anything about medically necessary care. It doesn't say anything about psychiatric care potentially decreasing healthcare costs or improving chronic conditions. It focuses on the fact that this is unjust and unequal, and that having our policy address those inequities is a fundamentally important thing to do. I'm waiting for oral health to get to the point where we can have these sorts of conversations and use this sort of language. So before we jump into some further conversation, when we think about what the future should hold, this is sort of my particular wish list. I don't know if it aligns with yours. I hope everyone keeps their personal oral health wish list with them. But oral health care is universally accessible, including both coverage and accessibility, because of course those are different. The dental workforce reflects the diversity and values of the US population and is provided by teams of providers. including dental therapists, dental hygienists, public health dental hygienists, EFDAs, primary care providers like myself. Reimbursement and care delivery are optimized for the delivery of whole person care, and communication and care coordination are easy to do. This is sort of my wish list. So let's imagine, instead of how emergency departments work now, how should they work to help people with oral health needs? What if a patient who visited the emergency department for a dental problem was triaged by a physician, nurse practitioner, or physician assistant who had been trained to manage oral health problems, then was treated by a dentist or dental therapist in the emergency department, and was immediately referred to the dental clinic for a next day appointment? I'll note that in some very special places, this is already beginning to happen. We need to learn from these models. What if patients who were hospitalized for a medical problem had their bedside nurse examine their teeth and apply fluoride varnish on admission, an action which was recorded and billed in the patient's EHR, kept their dentures with them and cleaned because it was a quality measure, then had a cleaning provided by a dental hygienist, and left with a follow-up dental appointment as part of their discharge paperwork? This is my colleague, Marlena, a dental hygienist who was a part of our pilot at Massachusetts General Hospital to provide dental cleanings to patients in the hospital. So again, these things are possible and are happening. They're just happening in small and slow ways for now. What if patients who came for a dental visit had vital signs collected and transmitted to primary care clinicians? Patients with known chronic health conditions could receive point of care testing, such as hemoglobin A1C in the dental chair, and a universal vaccination database allowed dentists to administer needed vaccines to child and adult patients with adequate reimbursement for all services. We are starting to see some of these things happen, but I think all of these examples demonstrate the need for structural changes to really demonstrate the support for these things. And we've already looked at this study together, but one of the things that's probably most important to take away from it isn't that it's possible to integrate oral health and medicine in the dental clinic, but rather that it required a very large health system and relatively fleet and creative reimbursement mechanisms and a focus on quality and patient-centered care in order to do so. We need big change, and we probably need it from the top to make these things happen. This is sort of a different framework to think about oral health integration, which is, rather than thinking about it as a bidirectional exchange, to think about it as a potential community impact. All of the different levels of ways that oral health can be implemented to reduce inequity and to strengthen our connections, not just with the health system, but to communities themselves. That's aspirational. We can briefly talk about the art of the possible, which is to think about integration as a spectrum. On one side, it's all dental, no medical. On the other side, all medical, no dental, no communication at all. And in the middle is perfection, which of course is not possible, even though we just talked about it. But you might be able to think about different opportunities or pilots or projects or goals that could actually sit somewhere on the spectrum, where even if it's not perfect, or even if it's a baby step, it's a step in the right direction, and that's important. And again, I'll note that all of these things are facilitated by large structural change that all of us can focus on advocating for, using the language of equity. These are things that increase equity and improve healthcare for our patients. That's why we need to have them. And these sorts of things, the external substandard lack of integration on our spectrum, are perpetuated by the way we do things now, by a fee-for-service model, by exclusion of dental coverage, by few referral options, and by lack of training. So let's reframe the language of oral health. When we talk about medical dental integration, what we really mean is comprehensive person-centered care. When we talk about electronic health record interoperability, what we really mean is a universal health record. When we talk about co-location, what we really mean is access. And when we talk about that blighted term to me, the oral systemic health link, what we really mean is health. Thank you all so much. It was wonderful to get to talk to you, and I'm looking forward to a really robust discussion. I'll stop my slides for now.
Thank you so much, Lisa. So we have some great questions coming in, so I'll just start rolling them off if that's okay.
Absolutely.
So why do you think MOM projects, or RAM projects, as you mentioned, continue to grow and are seen as a solution to the access problem? I tend to see the same providers traveling to projects and students participating and providing the backbone of staffing and work for these events. Is this helpful to the communities they are trying to serve?
This is a hot topic. I appreciate that you're asking this question. And I have had the great honor of hearing Carlos answer a question similar to this in a way that was probably much more diplomatic than I'm going to be able to do. The short answer is that I don't think any sort of charitable endeavor is a sustainable mechanism for care. And that if we actually want a system, then we need to build systems that take care of people. I think the perhaps more philosophical answer is, would you want your dental care to be provided in that setting? Is that how you want your dental care to be delivered? Because I sure wouldn't. I would feel really scared and really dehumanized to get my care in that way. And to me, that's kind of the answer. That's certainly not to dismiss the hard work of the people who are involved in this project, and they're certainly meeting a need. But having person-focused, community-embedded care probably requires a lot more structure than a single mission outcome. And on the flip side, I do have some concerns that having individuals believe that this is the solution, that they are a part of the solution by doing this, makes it harder for us to have more difficult conversations about structural solutions, like what our workforce looks like, how our workforce is distributed, how we train dentists, who becomes a dentist, who does dental care, and who covers dental care, which can sometimes muddy the waters.
Yeah, so I want to piggyback on that with a question. I heard Leo Rouse, who is a Dean Emeritus of Howard and past ADA chair, ADA chair of the board and American College of Dentists president. He gave a presentation maybe 2 or 3 years ago about this notion of dentists owning oral health, and that for pretty much in perpetuity, we have owned this concept of oral health, and we take it very seriously that we own it as dentists and dental hygienists, or even maybe dental therapists and dental assistants. But that now you see other health providers beginning to go into the oral health space. So whether that is nurse practitioners that are doing different things. I actually just read recently about the American Medical Association approving a procedural code.
Silver Diamine fluoride, yeah.
Right, for applying silver Diamine fluoride. So, I think it's very interesting. You brought up this notion of, who's a dentist, who does the dental care, who gets, and I think, at least from an ethical perspective, I think that's one of the hard questions that we as dentists in the dental profession and dental hygienists maybe have not really faced, is that we don't have this copyright on providing oral health care delivery. And I think we're getting pushed, maybe reluctantly, out of that comfort will. I don't know, do you have thoughts about that?
Oh, I totally do. And I'm so happy you mentioned silver Diamine fluoride. I was really enthused to see that. I wrote a piece a long time ago. It was kind of just like fiery about claiming we should train physicians how to extract teeth. Because if you look at state dental practice acts, the only thing dentists can do that other providers can't is restore teeth. So silver Diamine fluoride, even tooth extractions, sky's the limit. But when it comes to restoration, that's where dentists kind of get their own little Damascene. And it's not like I think we should stick to that necessarily, but I think it's a really interesting point because it does sort of speak to how much we've kept this little cabal where like we own oral health, and as a result, other people are more hesitant to be a part of it. And I would argue like don't understand its importance because it's been so siloed. Part of the reason I chose to go to medical school was realizing that, within our own wonderful, slightly dysfunctional, but loved world of dentistry, change was very slow to come. And there were not that many of us. Dentistry is a small world. You get in just a couple more voices from the rest of the healthcare system and change will come whether we want it or not. Their voices can be thunderous. And honestly, I think that's one of the things we're seeing with this evolution in Medicare policy. It really didn't take very much from the broader healthcare system to say, oh, of course we should have dental coverage for us to start to see changes that took 50 years previously. I don't see it as a threat. I see it as an opportunity, but I think, dentists tend to be a little on the detail focused side. And I think that for a lot of people that change can feel a little threatening. But hopefully as we see it evolve, it becomes seen as something that's more fundamental and more important for the patients we take care of.
Yeah, that's awesome. Thanks for that perspective. So we have another question The attendee says, thank you so much for this great eye-opening presentation. What have we done already, or what can we do from an advocacy perspective to get dental procedures covered under insurance as a necessary medical need? Also, why do you think the ADA was against the coverage for dental procedures under Medicare?
All right, so how can we advocate for dental procedures under necessary medical need? To be honest, I don't know. I was pretty surprised when that guidance came out, and I think a lot of people in the health policy world were kind of scrambling to think about what it could mean, because there is kind of this question of like, how broad do you go? What is a medically necessary need? And I think for me, the answer is like, if we say that, what is the purpose of healthcare? Is the purpose of healthcare to keep people alive when they would be dead? Is it to decrease suffering? Like if you define healthcare access as, keeping people healthy and well and happy, then I would argue all dental care is medically necessary. I don't think that CMS is going to go that far, but I think that's where we should be starting. Because I think right now what I'm seeing, and I'm grateful that everyone is doing all this advocacy, right now what we're seeing is like, oh, then people with diabetes should definitely get dental care, as if that's like progress. But again, that's leaving a lot of folks out in the cold, which has sort of been the story of dental care for a long time. So I think it's more about talking about the things we see that other people don't see, which are people with really intractable dental disease who have suffered and who have not had access to care, and making that the story. The story is about suffering and the story is about what's right. In the weeds, I think what CMS is actually doing is starting to build the infrastructure to provide a Medicare dental benefit, because even if they only cover it for a few people, they're going to learn how it works. They're going to learn how billing codes work. They're going to be ready to pounce when we get access for more folks. So I'm certainly not saying this is a bad turn of events. I just think it's really important for us to have a moment where we acknowledge that this is not equity-focused language when we talk about the benefit. And why was ADA against Medicare? I will note, I am an ADA member. I have chosen to be an ADA member, but many of the policies they advocate for, I think, come from the perspective of small business owners who feel perhaps a little threatened by change, whether or not the evidence supports that, rather than focusing on patient access and patient well-being, which is in part why I shared the fantastic letter by the NDA, which is an organization that has never had that problem. The things that the ADA will tell you is that they would prefer to have a benefit external to Medicare Part B, which is sort of how other outpatient services are paid for, and also only for adults who make 300% or less of the federal poverty line. Both of those things are actually just restricting the number of people who would benefit from Medicare dental benefit, making it perhaps like Medicaid, which very, very few dentists actually accept. Only about a third of dentists accept Medicaid in any capacity. So making it easier for people to opt out of this new service and making it harder for people with the Medicare dental benefit to go see someone and get care. And then the other part of that is making it so that the dental services are reimbursed in a different way from the rest of the medical system, and perhaps more like dentistry has always been paid for. So these are ways of protecting dentistry from having to adapt to change. I would argue that when that change could potentially increase oral health care for 64 million Americans, that is an unethical approach. But that is the ADA's perspective currently.
Sure. Well, thank you so much for your perspectives there. I want to push a little bit around this medical necessary concept, right? And this is just anecdotal. It's interesting. I had a patient just the other week who uses like a health savings account, card to pay for a large balance of her care. And this was the first time I've been in practice 15 years, and maybe this is common other places, but this is the first time I had a patient bring in a form. She brought a water pick from our office, and she needed a signature on the form that water pick was medically necessary in order that she could be able to use her health savings account, to pay for the water pick. And it was just a fascinating, I think everybody knows I'm pretty heady and ethereal. And it's like, this is fascinating from a philosophical standpoint. I buy glasses every couple of years, and I've never had to fill out some additional paperwork to use my health savings account to pay for glasses. It's a part of my healthcare, right? So it just was a fascinating concept to me that there is still such this delineation in many ways around that. And the other thing I'd say, I am an ADA member, I am an NDA member, I'm an HDA member, I'm a Society of American Indian Dentist member. And I do think, from an ethics perspective, I think we have to ask a question like, what is the precipice or what is the rationale for various professional groups, right? What do they do? What is their their service? What is their modus operandi? Like, why do they exist? And so I think the ADA has done a lot of great work, but I think in many ways, they are a member services organization, right? They're not an advocacy group. I've done CE for the ADA. I've had honorarium from the ADA. So maybe I'll get in trouble for saying this, but I think that's okay. Like, to me, as an ethicist, just say who you are. Like, if you're a member services group that is advocating for the best interests of your members, which are a lot of small business owner dentists, that's fine and that's wonderful. But I think you need to say that and articulate that as your narrative versus I think some of the other groups like Santa Fe or different groups that are really kind of in the trenches around advocacy and policy and things of that nature. So we have another question. We're trying to come up with an ILO for medical students in our school to teach them to look beyond just the back of the mouth during an exam and to learn to identify common dental issues in order to make appropriate referrals. We also do regular screenings for diabetes and hypertension at our school. So awesome. I don't know if you have feedback or thoughts about that comment.
I think what you're doing is great. I've been on both sides of both of those initiatives. And I think like the thing that always comes up, at least in the systems I've worked in, is the infrastructure to complete those referrals and how to ensure they're getting done. So when it comes to like teaching, so I'll tell you a story. I had a mentor whom I really respect, who's a physician, send me an urgent page. Like my pager went off and I was like, in the middle of clinic or something, and I call him back and he's like this incredibly poised, super smart guy. And he's like, I have a patient and he has a toothache. He's not my patient. I don't know anything about him. He has a toothache. Should I send him to the emergency department? Should I order a CAT scan of his space? Wow. Like, those are thousands of dollars. Like, these are just like incredibly expensive interventions that come from a really good place, but they also come from ignorance. Like, and he paid, just credit, he paged me. He, being like, what should I do? And I had to be like, don't do those things. You're going to give him like, does he have a fever? Like, can he swallow? Like, okay, we're good. Like, we're going to give him some amoxicillin and like, I'm going to send you a list of some dental clinics. And I think like part of it, and when we think about like teaching medical students how to screen for oral problems, are we setting them up to then refer appropriately? Or are we just asking them to experience, there's a saying in medicine, like, don't order a test if you don't know what you're going to do with the results. Are we just teaching them how to do a test where they won't know what to do with the results? And to a certain extent, I think the flip side is true in dentistry. Like, if you're screening for hypertension, which I think is fantastic and evidence-based, if you are telling patients with a blood pressure over 160 that they can't have elective dental care, which is what the ADA currently recommends, and you're not actually ensuring they get access to a physician, all you're doing is denying them dental care. And to be clear, Dr. Raghavendra, I'm not saying you're doing that. I think this is truly excellent. But I think these are some of the challenges that we face from a structural perspective in making these things happen. Like, we're still working within these silos, and bridging those gaps is still like really hard and requires kind of individual effort, when for a lot of other things, it doesn't, it just works. And I wish we had that in oral health.
Yeah, and so I know our time is getting away from us, but I want to push maybe one or two other questions that I have in my mind, at least. And so one of the things you've brought up is referrals, right? And so I think about EDs, emergency departments, emergency rooms, and there's a litany of research of how large the figures are in terms of total cost around dental care. But there seems to be, at least to my knowledge, a real gap between, they get an amoxicillin script, they get a pain med script, maybe a referral is given, maybe it's not. What do you think are some creative ways that dental schools can begin to maybe help bridge that gap?
Yeah, it's so hard. I think community-based externships are like a core to that, not just because they're going to like put trainees places where they're needed, but because they expose trainees to communities and sort of what the leadership role of a dentist should be beyond just like our own clinic or your own practice or whatever. I think that's really key because it emphasizes the social and emotional development of dentist leadership, which I think we're lacking. On the flip side, and I know this is something that you agree with, Carlos, is the way we admit dentists to dental school and the selection criteria we use. I don't know why being able to tell you where a hole got punched in a piece of paper that got folded is something that like makes me better at being a dentist. And just to sort of give that there's evidence, like in medicine, the MCAT changed about 7 or 8 years ago. One of the things that they made is a requirement. There's now a psychology section of the MCAT. And I have a friend who's a psychology professor at a liberal arts college. And he called me being like, the people in my intro psychology class have totally changed. There's all these cutthroat pre-meds and I don't know what to do. We had to change his pedagogy to accommodate them and keep them from basically, you know, sabotaging each other and calming down. But I think the takeaway is that like the American Medical Association, or sorry, the AMC said, it is important to understand psychology. Like this is an important and fundamental trait that you have to understand to be a physician. And I don't think standardized tests are like the answer, but I think thinking very critically about if we're going to have a standardized test, we think that's something we still need, which I'm not sure I believe. What the content of that test is can drive the preparatory training of pre-professionals who then enter our field. And I think that that's an opportunity that we're not really using.
You know, that's fascinating. I think the last thing, we don't have any questions from the participants, but I want to push, just lastly, you shared the photo of Diamante Driver and this notion of, I don't know, I think it fluctuates a little bit, but around 38%, something like that, of dentists in the United States, at least, are enrolled as Medicaid providers. Now, I think that's a little complicated because we don't really know what that means fully, right? I can be enrolled, but actually not see any patients, or I could limit the days of the week that I see patients that utilize Medicaid as their primary form of insurance, or I have more than one location and one location accepts Medicaid as a form of payment and another location does not. You know, there's, and I'm not inciting, I'm not making a verdict or edict around if those are policies that folks do. But unpack a little bit or talk to us about like, why do you think that percentage is so low? Particularly when, you know, everyone at least espouses these altruistic sensibilities around entering into the profession. So do you have thoughts about that at all?
I have so many thoughts. I don't have like a definitive explanation. I'm thinking about some data that Natalia Chalmers shared, who's now the dental director at CMS and just an incredible person. But she shared these cool graphs and it shows sort of different states, and one axis was reimbursement rates, like so Medicaid, as many of you know, reimburses at lower rates than private insurance, but it showed sort of how low, like, and then whether physicians accepted Medicaid. And it's correlated. It's not surprising. If your state has a higher Medicaid reimbursement rate, then there are higher rates of physician enrollment in Medicaid. That is not true for dentistry. It's a flat line. There's no correlation between Medicaid reimbursement rates and the percentage of dentists that are enrolled in Medicaid in your state, which is crazy because if you talk to dentists, they're like, oh, they don't reimburse enough. I can't be enrolled in Medicaid. It doesn't reimburse me enough. But somehow that's not it. Like we are, whatever is driving that decision, we are missing the mark. Like, I don't think we fully understand. And I know, we know that like female dentists and dentists of color and dentists who come from underserved communities are more likely to accept Medicaid, but I hesitate to say that's the solution because I think, again, that is, you know, putting more work on people who come from structurally underserved communities, and I think that's unfair. But I don't know what the answer is. Like, I think there's something ineffable or something we haven't studied yet that actually explains that, and we need to do a lot of work to unpack it because it is not the reason that dentists are giving. So we have to like go way back to figure out what it is, but I don't know how we do that.
No, that's great. Well, we are at time and actually maybe a little bit over, so I so appreciate your ability to stay on and dialogue with us, and you shared such great information. I appreciate all of you who signed on and participated with us live and had lots of questions and great engagement. So thanks again, Lisa, for being with us. We have one more day left of our third annual Inclusive Excellence Week. So we'll be here tomorrow at 12:15 Eastern Standard Time with one of VCU's own faculty from our Department of African American Studies, Grace Gibson, who will be talking about the ways that our cultural images influence bias, particularly in the healthcare system. So we're looking forward to that. And thanks so much again, Lisa, for joining us today.
Thank you, everyone. This was such an honor. Take care and have a great day.
Thank you.
Bye.